Silent endometriosis involves the presence of endometriosis lesions without causing noticeable pain or discomfort. 20 to 25% of endometriosis patients are estimated to live with silent endometriosis. Despite the absence of obvious symptoms, silent endo can still lead to complications, especially concerning fertility. You might have noticed my emphasis on obvious because while silent endo might not present with characteristic pain symptoms of endo, your body might be giving you less obvious or uncharacteristic signs that endo is in fact brewing beneath the surface. Welcome back to the Endo and Fertility Space channel. In today's video, I'm breaking down what you should know about silent endo, namely what symptoms might indicate silent endo, what biomarkers like cervical mucus and or temperature shifts can tell you about endo, and what tests to pursue for more information. We are also going to discuss relevant lab markers you might consider that can give you some insight into silent endometriosis and how it might be affecting your body. Inflammation often presents with pain, but with an absence of pain, does your endo management or fertility preservation strategy need to be as aggressive as somebody who does have pain symptoms? I'll be addressing this question in today's video as well. Before we jump in, please like this video, share it with a friend, and hit that subscribe button for all the endo and fertility content here on YouTube. If you are not experiencing characteristic pain symptoms with silent endometriosis, what are some other symptoms you might be on the lookout for? Just because endometriosis doesn't present with characteristic pain symptoms doesn't mean it's not manifesting in other ways. Let's talk about a few other common symptoms of endo. One symptom to keep your eyes peeled for is heavy or abnormal bleeding. One study showed that 50.8% of endometriosis patients report heavy or abnormal bleeding. Bleeding that lasts over 7 days, requires pads or tampons be changed every 1 to 2 hours, involves passing large clots larger than a quarter, or that involves blood losses of over 80 mils or a third of a cup would be considered heavy bleeding. Bleeding mid-cycle or excessive spotting before or after your period, which we'll dig into in a little bit more detail in a moment, or bleeding after intercourse can also be considered abnormal. Another set of symptoms to keep your eyes peeled for are digestive symptoms. Up to 90% of endometriosis patients report digestive symptoms, including but not limited to constipation, bloating, nausea, or vomiting. Digestive symptoms seemingly out of nowhere are often the first subtle sign of endometriosis, so keep your eyes peeled for those symptoms. 55.6% of endometriosis patients also report feelings of low mood, depression, or hopelessness. Despite not having pain symptoms as somebody with silent endometriosis, if you experience drastic mood shifts or feelings of depression or hopelessness out of nowhere, these are definitely symptoms that are worth investigating. Urinary incontinence, recurring UTIs or seemingly recurring UTIs, bladder pain, or pain with urination are yet another collection of symptoms to keep your eyes peeled for. I think we could agree that it's normal or would be considered normal for most people not to put too much weight on the occasional bladder urgency or a UTI, but unfortunately there are several reported case studies of silent loss of organ function, in this particular study kidney function, due to endometriosis. So if silent endo is something you're suspicious of, it's worth having yourself investigated. Speaking of UTIs, if you are presenting with symptoms of a UTI but cultures are negative, this is another symptom to look out for that might indicate silent endo on the ureters or bladder. Abnormal fatigue is another symptom often reported by endometriosis patients. Fatigue can be a consequence of inflammation and pain symptoms, but it can also result from what some researchers call silent inflammation. If you are suspicious you have silent endometriosis, the most likely symptom that might have you thinking that this is the case is infertility or subfertility. Most women with silent endo are introduced to this diagnosis following infertility or a failed assisted reproductive technology round of IUI or IVF. Endometriosis is found in about 30 to 50% of women with infertility, highlighting a strong association between endometriosis and reproductive challenges. In the realm of fertility, 18.9% of pregnant women with endo report at least one pregnancy loss, 3.9 report up to 2 losses, and 2.1 report 3 or more losses, which, despite being low percentages, are still higher comparatively to women who do not have endometriosis or suspected endometriosis. We can all agree that this is a sad and unfortunate symptom to be experiencing, but if you can relate and you have not been investigated for endometriosis, recurring losses is definitely a sign that you should be investigated. So let's switch gears now and talk a little bit about biomarkers and what are some biomarkers you might consider deep diving that can give you a bit of information about whether endo may be brewing beneath the surface. Now, I want to preface by saying that these are not diagnostic for endometriosis or silent endometriosis. This is just information to help you put the pieces of the puzzle together and hopefully help you get that endometriosis diagnosis that you may be after. So we've talked about some non-pain symptoms to keep your eyes peeled for, but what about biomarkers? A biomarker is a measurable characteristic that indicates a normal or abnormal process, condition, or disease in the body. This is where I love to bring in a discussion on NAPRO technology. If you're familiar with NAPRO technology or the Creighton model, you're probably familiar with charting and how different cervical mucus patterns or temperature shifts can highlight issues or problems that require attention. Let's talk about a few of these patterns and what they can mean. None of these patterns, like I mentioned before, are conclusive for silent endometriosis. However, they can give you information that you can then use to pursue further investigation or support. Okay, the first pattern I want you to pay attention to is a lack of peak cervical mucus. This is mucus that is stretchy, so it will stretch 2 inches or more. It's lubricative, so you should be feeling a slippery sensation when you wipe after urination or passing a stool, and is clear in color. This cervical mucus is produced as estrogen starts to increase leading into ovulation. So a lack of this egg white, slippery, stretchy cervical mucus could indicate ovulation issues. This is a helpful sign to look out for if you have a fertility-focused objective, whether or not it points towards silent endo. While this pattern is not conclusive of silent endo or anovulation, so having anovulatory cycles where you don't ovulate, if you are experiencing this pattern, you might consider some hormone labs to confirm ovulation, like peak estradiol, LH, FSH, and a luteal phase progesterone. You might also consider an ultrasound series to confirm ovulation. I talk a lot about what these numbers should look like in other videos, so I'll link to some of the videos where I discuss these optimal ranges in the show notes below, and then look out for future videos on this topic as well. Okay, the next pattern I want you to pay attention to is quite the opposite. So this is an excessive cervical mucus pattern. If your peak cervical mucus is excessive and spans well over 6 days, this can be suggestive of hormonal irregularities. Excessive cervical mucus, specifically in the luteal phase, so the phase following ovulation to the start of your next period, can be a reflection of high estrogen levels, which may or may not be consistent with endometriosis. Having high estrogen or patterns reflective of high estrogen, again, doesn't mean you have endo or silent endo, but again, it's an abnormal pattern to keep your eyes peeled for that can guide further investigation. In the case of this pattern, consider having your luteal phase estradiol levels checked. Because estrogen is made from testosterone, having those numbers checked as well, so testosterone, androstenedione, DHEA sulfate, can be helpful for understanding where all that estrogen may be coming from. High estrogen relative to progesterone can also cause more pain and affect fertility outcomes. So if you have a fertility-focused objective, this is good information for you to have. So maybe also consider having your luteal phase progesterone checked roughly 7 days after ovulation. Similarly, if your cervical mucus is changing rapidly over a short window of time, so if you're going from peak type cervical mucus to watery to creamy over a 2 to 3 day window, this could also be suggestive of hormonal irregularities. This might be that your estrogen or your progesterone is bouncing up and down, or maybe even your thyroid is dysfunctional. There are two criteria for identifying cervical inflammation. One is strictly cervical mucus that stretches only a 1/4 inch, or tacky, which stretches 1/2 to 3/4 inch, or gummy discharge, which doesn't stretch, it just rebounds if you push it in between your fingers. And that presents during the early pre-peak phase of the cycle. This is a little bit confusing, I totally understand, but if you're seeing cervical mucus that doesn't stretch very much, or you're getting sort of like a gummy bear type consistency discharge, that could point towards cervical inflammation. And again, this is specific to the pre-peak phase, so the 6 days leading into ovulation. The second criteria is any sticky, tacky, or stretchy cervical mucus that stretches 1 inch or more, or a gummy discharge. So again, a type of cervical mucus that doesn't stretch, but it just you can kind of squish it between your fingers. And if that type of cervical mucus is seen anytime from the 4th day post-ovulation, that could also be a sign of cervical inflammation. So again, 4 days post-ovulation, if you're seeing this sticky, tacky, or stretchy or gummy discharge anytime from the 4th day post-ovulation, could be an indication of cervical inflammation. So despite cervical endo being rare comparatively to endo located in other areas, this pattern is very specific. So if your cervical mucus is lining up with these patterns, this is an important sign to pay attention to, because it can guide further interventions and helping that cervical inflammation so that you can then overcome your fertility barriers. Okay, another pattern to pay attention to is a continuous wet without lubrication pattern. So if you're constantly feeling wet discharge, but there's no lubrication, so when you wipe, there's no like slippery sensation, this pattern could indicate a low-grade infection of the cervix. Now, again, I need to clarify that this is not conclusive for this, but it's a pattern commonly seen in Creighton charting or NAPRO technology that might point towards a low-grade infection of the cervix. So in the NAPRO technology textbook, they did a study, it was a small study, and in 18 patients with this pattern, 15 had positive cultures for some kind of low-grade infection of the cervix, and when treated, this continuous wet pattern went away. Okay, now let's switch gears and talk a little bit about cycle patterns and what cycle patterns to pay attention to that might give you a little bit of information, might give you some pieces of the puzzle to help determine if you may be living with silent endometriosis. So again, as always, I want to preface that none of these patterns are confirmation of silent endo. However, there are various hormonal patterns that are more consistent in people with endo, and in this section, I want to break those down. So the first pattern is a low progesterone pattern. So more and more research is showing the relationship between low progesterone or progesterone resistance and endometriosis. Now, progesterone resistance doesn't always mean low levels of progesterone, but it can. A few cycle signs to look out for, firstly, is spotting for several days before the start of a heavier flow, or tail end brown bleeding after your heavy flow has subsided. And if you're getting this spotting before or after alongside signs of excess estrogen or low progesterone, like mood changes, anxiety, poor sleep, or estrogen excess symptoms like breast tenderness or fluid retention, this could be an indication that you have low progesterone. So even if this pattern is not conclusive of silent endo, this is an indication of a hormonal imbalance that is not ideal if you have a fertility objective. The next cycle pattern to keep your eyes peeled for is mid-cycle bleeding or spotting. So this is reported to occur in 2.8 to 5% of women and can occur in response to either high estrogen levels. Ovulation is in fact the highest estrogen phase of the cycle. So when it gets extremely high, it can result in this breakthrough or mid-cycle bleeding or spotting. And that is common in the endometriosis population. It could also be caused by inflammation, which again is more likely in the endometriosis population, and that inflammation makes the uterine lining unstable, causing that sort of breakthrough or mid-cycle bleeding. Or it could be caused by something anatomical like an endometrioma, polyp, or fibroid. Okay, now let's switch gears to a conversation about temperatures, because this is another biomarker that can give you some helpful information about whether you may be living with silent endo. So if you're on a trying to conceive journey, you might be aware that one way to monitor fertility hormones and ovulation is via temperature monitoring. If you do not see a 0.5 to 1 degree Fahrenheit or 0.3 to 0.5 degrees Celsius increase in temperatures after ovulation, this could definitely be a sign of suboptimal progesterone levels and or high estrogen levels, or potentially suboptimal thyroid function. Again, while this pattern is not conclusive for endo or silent endo, these are signs to look out for that can give you some information about whether or not you need to pursue a silent endometriosis diagnosis. Okay, what about some other testing options? Are there other options that you can consider? The first test I want to talk about that might be worth doing is the Receptiva test. So the Receptiva test includes the BCL6 marker, which is a marker for identifying inflammation of the uterine lining. BCL6 is found in over 50% of women with unexplained infertility and corresponds with a positive endo diagnosis in about 80% of people who confirm via a laparoscopy. The Receptiva test can also identify a chronic bacterial infection of the uterine lining called endometritis. Despite not being diagnostic for endo, research shows endometritis is more prevalent in endometriosis patients. So this is definitely a test that might be worth doing if it is accessible to you locally. You can also do not exactly the same test, but you can do a version of this test through Fertility, which I'll talk about in a moment. Another set of tests to have done or consider having done is inflammatory markers, so specifically CA125, ESR, and or CRP. So deep infiltrating endo with or without pain symptoms can cause these markers to elevate. And so knowing that they're elevated can already give you an idea that there's some inflammation that maybe is not manifesting as pain symptoms. Okay, Fertility also offers a uterine immune panel. You can get a similar but different panel that tests inflammation systemically. So they do offer you two different sets of information. The Fertility menstrual blood sample can give you information about inflammation in the uterine lining. It can also give you information about whether something may be going on with the immune system within the uterus. If you do a blood lymphocyte map, which is often what it's called, or a white blood cell panel or an immunological panel, it can give you similar information, but it will tell you whether something's going on with the immune system more systemically. So you can often get your hands on these types of test panels through a specialty lab or a reproductive immunologist. And these panels test for immune markers like natural killer cells, T cells, B cells, and other immune cells. There's a great book, which I have next to me here, called Is Your Body Baby Friendly? And in this book, the author breaks down various immune abnormalities. Some of these immune abnormalities are more prevalent in people with endometriosis. So whether or not you have a definitive diagnosis, having these varying pieces of the puzzle can help move you closer to a diagnosis, or at the very least give you information that you can then use to make decisions. Okay, so we've kind of already talked a little bit about endometrial cultures because doing the BCL6 or the Receptiva test, it is an endometrial culture, but we have seen that there are various pro-inflammatory stains that occur alongside abnormal uterine bleeding. So if this is something that you experience, if this is a symptom you experience and you want to pursue additional testing that might give you information about why you're having this abnormal bleeding, whether it could be tied to silent endometriosis, then a uterine culture in the form of a biopsy or the Receptiva test can be helpful. Enterococcus, Gardnerella, and Staphylococcus are just 3 strains that are found in higher amounts in people who have this abnormal bleeding, and this information is pulled from page 395 of the Naprotechnology textbook. So while we don't have a massive body of research to show this connection, vaginal dysbiosis is loosely tied to endometriosis. So a vaginal swab may be a low-cost test option to pursue. It will not be diagnostic or definitive for silent endometriosis, but whether or not you end up getting a silent endometriosis diagnosis, we know that the vaginal microbiome is implicated in fertility outcomes. So especially if you have a fertility objective, knowing that your vaginal microbiome is lactobacillus dominant is very valuable information. So because your symptoms aren't as obvious or pronounced as somebody with symptomatic symptomatic endo, I would argue it's even more important for you to stay on top of routine labs for subtle hints. For example, routinely have a white blood cell with differential lab completed, test your thyroid function, your thyroid antibodies, test your hormones inclusive of testosterone, DHA sulfate, progesterone, estrogen, and prolactin, do liver function tests, specifically short form to AST and ALT, have your cholesterol and metabolic health markers tested regularly as well. And the metabolic health markers would include things like your insulin and your fasted glucose. As somebody with silent endo or suspected silent endo, you're not able to determine if endo is progressing based on a progression or a worsening of symptoms. So you have to be strategic about how you determine if this is the case. If you're not experiencing pain symptoms, does your endo management strategy or fertility preservation strategy need to be as aggressive as somebody who is experiencing pain symptoms? So as we've already discovered, as we've already talked about in this video, silent endometriosis can present with silent loss of organ function. I linked to a case study where kidney function was affected silently without any obvious symptoms in somebody who had endometriosis. You can also often see tubes becoming blocked or egg quality being affected without any obvious pain symptoms. We've also discussed this concept of silent inflammation. And so for these reasons, your management strategy should be as aggressive, if not even more proactive or aggressive than somebody with symptomatic endometriosis. I have several other videos that dig into preliminary steps that you can take as somebody who suspects endometriosis, or if you have a fertility focus, I have a video including 8 steps to getting pregnant with endometriosis. So I highly encourage you to check out those videos because these are very complex topics that require way more time than I can provide in this specific video on silent endometriosis. But I did want to leave you with just a few quick tips that you can use to kind of get you started on this silent endo discovery journey. Okay, so as we've already established, you're not going to present with symptoms as somebody who suspects or has silent endometriosis as somebody who has symptomatic endometriosis. So the first thing that's really important for you to do is keep your eyes peeled for those subtle signs, those shifts in temperatures, in cervical mucus patterns, in cycle lengths, or symptoms related to your cycle. Keep on top of these changes. They're such subtle signs, but they can give you truly profound information about what may be going on in your body, as we've already established. I would also keep on top of having routine labs tested. Again, because your symptoms or the change in your symptoms isn't as obvious as in somebody who maybe went from having pain 1 or 2 days in their cycle to now having pain for 3 weeks out of 4 weeks every month, right? That's like a big measurable difference that you can see in pain symptoms. But if you're living with silent endo and you can't see that difference in symptoms, you need to rely on something in order to tell you whether the endometriosis beneath the surface is progressing or getting worse. And you can do that sometimes through some of the things we already talked about, like looking at the charting, looking at the cervical mucus, looking at the temperature shifts, but you can also dig a little bit deeper into your routine labs to determine if something that's relevant to endometriosis is getting better or worse. So an example of this might be your thyroid function. We know that sluggish thyroid function is associated with more severe forms of endo or more aggressively proliferating endometriosis. And so if you're able to look back a year ago or 2 years ago and saw that your TSH was within an optimal range, and then 2 years ahead in the future, you're seeing that your TSH has jumped up to 5 and the rest of your thyroid panel is pointing towards sluggish thyroid function, you know that that's an action item that you can intervene on that would likely have positive spillover effects into your endometriosis or your silent endometriosis. Another example might be something like progesterone. We know that progesterone is anti-growth promoting and anti-inflammatory. And so if you're able to see a pattern where 2, 3, 4 years ago, your progesterone in the luteal phase was optimal and healthy, and now 2, 3, 4 years into the future, your progesterone levels are really low and suboptimal and kind of struggling to increase, you know that that's an area that you can intervene to support your body with silent endometriosis. I would also consider monitoring your AMH and markers of inflammation. So if you're not having characteristic pain symptoms, or if you don't have large endometriomas on your ovaries, chances are these markers of inflammation like ESR, CRP, and CA125 probably won't elevate too much. However, it's not impossible that they'll elevate if you do have silent, deep infiltrating endometriosis. So these are markers that you could look to tell you, you know, how deep infiltrating is the endo, how aggressive is it, how aggressive does your intervention need to be, and then AMH can give you some information about how that silent endometriosis may be affecting your ovarian reserve. I know I'm using some interesting language, and I want to be very clear. None of the things that we talked about shy of having a scan or an excision surgery can confirm the silent endo, but if we pull all of these things together and you're fitting sort of a symptom picture, you're fitting some of these patterns, at the very least, you can take that information to your doctor, present that information, and that might help you access a diagnosis faster. So even markers of, you know, CA125, CRP, ESR, there are lots of reasons why these may elevate, but if there's no obvious sign like a recent accident or some recent trauma that might cause inflammatory markers to elevate, if they're elevating out of nowhere, then that can definitely give you some indication that there's something brewing beneath the surface that you're maybe not aware of, like silent endo. Okay, whether or not you have silent endo, symptomatic endometriosis, whether you're completely healthy, living with PMS, living with some kind of metabolic dysfunction, the foundations are always, always important. So eat an anti-inflammatory Mediterranean style diet and support the foundations, which include sleep, exercise, blood sugar balance, and stress management. And I talk a lot about these in previous videos as well. Not everybody needs supplementation, and I'm a huge fan of strategic supplementation based off need, but I find that there are 3 supplements that most people with endometriosis can benefit from, and those include, first, a quality multivitamin. Complementing nutrient gaps is one of the easiest ways to support your body with endometriosis. We know that there are a few nutrient gaps that can exacerbate symptoms of endometriosis. And so complementing your diet with a quality multi or prenatal is a super easy way to mitigate any negative effects from nutrient gaps. The second supplement is a quality high EPA omega-3 supplement. This helps with inflammation, and if you're not eating 3 to 4 oily fish servings per week as part of your diet, you're going to be deficient. And so if you're eating the 3 to 4 oily fish servings every week, you don't necessarily need to supplement. You might not need to supplement, but if you're not getting those servings in, then an omega-3 supplement is a supplement that most people could benefit from. And the last one is magnesium. Magnesium is really important for PMS, for supporting the nervous system, for supporting estrogen elimination, for muscle contraction and relaxation, whether it's manifesting in pain symptoms. And so, you know, magnesium comes in many different forms. You can take it as a powder, a capsule, a spray, through Epsom salt baths, but this is a great supplement to consider as well. And my last suggestion to you is start the search for a skilled excision surgery, especially if you have a fertility objective and you haven't had success with conceiving or becoming pregnant. Pop online, search up a skilled, experienced excision endometriosis surgeon near me and request a referral. Assess to see if they're taking patients, request a referral, and at the very least start that process of getting assessed and getting that concrete diagnosis. We do know from research that excision surgery does improve fertility outcomes, and conception rates and live births increase in people with endometriosis who pursue endo-excision surgery. So definitely something to consider. This is the gold standard way of getting a diagnosis, and so definitely want to encourage seeking out a skilled surgeon. Thank you so much for tuning into today's video. Please don't hesitate to drop any comments or questions in the comments below if you have any following this video. Like this video, share it with a friend, and please subscribe if you haven't already, and I will see you in the next video.